Sure. So thank you for the introduction. So just kind of to reiterate, this is going to be a very brief overview, and then we'll go over some cases. And in like the coming weeks, we'll probably have further sessions to talk about other drugs you guys might be seeing. So to begin with, the most critical thing for most of these ICU patients is pain management. And this is going to help them do two things. It's going to help them be comfortable while they're on the ventilator. And the other thing it's going to do is going to depress their respiratory drive, which is something we really want to achieve for these patients. Because their main issue is ventilation, they're on difficult vent settings that make it very uncomfortable to breathe. And so we actually want to depress their respiratory drive and enable them to be synchronous with the vent. So typically how you probably see these agents ordered is to something called a CPOT scale. And this is included here. I know this was circulated prior, so hopefully you've had a chance to look through it. This is a scale which measures the presence or absence of pain. So any score greater than 2 indicates the likelihood that there's pain present. And so analgesia should be started or should be titrated up. In some cases, and more often in many of these patients' cases, these agents are going to be titrated to RASS, which is their sedation score. So the more negative that RASS number is, the more sedated that patient is. And the higher the number is, and as it moves into the positive, means they're either awake and maybe even agitated and aggressive. So the most commonly agents you're going to see utilized, at least to start with, are going to be fentanyl and hydromorphone. So the dosing is here for your reference. The important thing to note is that opioids really don't have any ceiling dose. So that means that there's no maximum dose. They are limited by the potential adverse effects, which you guys are all very familiar with. And so for those of you with prior ICU experience, you might notice that these patients are on much higher doses than what you're used to. And that's because by and large, many of these patients are much healthier. They're requiring much more complicated ventilator settings, and they're probably just using a lot more drug because of all of those combinations of factors. So fentanyl and hydromorphone are the most hemodynamically even drugs, and they also are not limited by active metabolites that accumulate in renal function. Because of that, they're our go-tos. As our supplies of these medications are depleted, you might see more providers reaching for morphine, which we typically don't use in this population because it's associated with histamine release that can cause hypotension, and there's a risk of metabolite accumulation in renal failure. So those are some things to be aware of, and especially when you're assessing these orders and assessing other potential alternatives, which we'll talk about in future sessions. Because we are in such short supply of these medications, one thing we've talked to our ICU providers about is starting enteral opioids in addition to these infusions up front. So increasingly, you should see these patients started on fentanyl patches, high doses of enteral oxycodone, perhaps even morphine and hydromorphone as like the drug landscape kind of evolves. So that's appropriate and actually recommended in these patients. So now let's move on to sedation. So in addition to requiring analgesia, these patients are also going to require a heavy amount of sedation in order to be synchronous with the vent. So that can be partially achieved through their analgesic regimens, but they're also probably going to need sedatives, particularly in the case of patients who are paralyzed. And we'll talk about why some patients need to be paralyzed in just a little bit. So as I mentioned before, this is the RASS scale, and these are our most commonly used sedatives, propofol, midazolam, and maybe we'll see more and more lorazepam and dexmedetomidine. Typically, what I want to highlight is these drugs use actual body weight for dosing, but because pumps are in short supply, you might notice that we'll have to dose these drugs off of ideal body weight to match our paralytics. And that's okay because we're going to be titrating these drugs to effect, but it's important to keep that in mind because you might see that they're on seemingly high doses of the drug, which then back calculate based on their actual body weight to a reasonable dose. For propofol, COVID patients in particular have been noticed to have high triglycerides. Levels up to 500 have been reported. Some institutions are continuing propofol up until the triglycerides reach 800. There's no evidence for or against this recommendation, but the important thing is just to monitor for signs of PRIS. So most crucially, that might be acid-base disturbances, changes in renal function, and creatinine kinase can be particularly helpful in those scenarios. For the other medications, dexmedetomidine should never be used in combination with paralytics because it doesn't provide deep enough sedation. So even if it is used, it should be coupled with another sedative, such as a benzo or propofol. And lastly, I just want to highlight that lorazepam, in patients with renal failure, its diluent propylene glycol may accumulate and cause toxicity, so should be monitoring the osmolar gap. So lastly, particularly sick patients are going to, in many cases, require neuromuscular blockers, and that's because in many times when we sedate these patients, they're still not synchronous with the vent. So they might be what we call bucking the vent. They might be coughing. They might be trying to inhale when the ventilator is trying to remove oxygen and remove air and enable them to exhale. So we might have to paralyze these patients. The most commonly used agent currently is cisatracurium, but you may increasingly see the use of rocuronium and vecuronium as we move forward. The important thing is that these patients all have eye care, so either their eyes should be taped shut and they should get eye drops. So the preferred agent right now would be the refreshed Celluvisc. That's because of the low frequency in dosing, which reduces nursing contact time. So now I'm going to pass it off to Paul to take over.
And then moving through, so those were pretty much the hallmarks of critical care and making sure that our patients are synchronous with the vent as much as possible. The other things that we have highlighted throughout our kind of textbook that we sent out throughout the system, you might see orders for inhaled vasodilators. The current guidelines don't really have any recommendations, but it might be something that you see. The thought is that it could reduce the pulmonary airway pressures as kind of like a last line agent for these ARDS COVID patients. Most commonly, pharmacy doesn't handle this one, but we'll use inhaled nitric oxide. But what you also might see as well are inhaled epoprostenol, either the Flolan or the Velitri. As far as I know, the Flolan is the one that we've been using most commonly. It's a continuous nebulization, but it's entered as Q8 and EPIC, just one thing to look out for. These medications are also dosed on ideal body weight, and stability is a big issue with these medications, so just something to consider when you see an order coming through when you're thinking about operationalizing these medications. And one thing to also highlight too is that the combination of inhaled nitric oxide and these inhaled prostacyclins is that they shouldn't be used together. Now, we also have vasopressors, which most of you are familiar with. We use these in hemodynamic shock. Oftentimes, where you'll probably see these a lot if you've cared for ICU patients before for things like septic shock or cardiogenic shock, whenever fluids aren't adequate enough to maintain an adequate blood pressure to perfuse our organs. With COVID specifically, our patients may present very similarly to septic shock due to systemic inflammation. The other thing we've been noticing too when looking through these patients' charts and taking care of them is that because they need such high doses of analgesics and sedation, which their adverse event profile is hypotension, we're actually needing to use vasopressors up front to maintain their blood pressure. Typically what you'll see for most cases of shock is the use of norepinephrine as a first-line agent, but we've also been seeing phenylephrine being used as a first-line agent as well. And then everything else kind of falls in play after that, and most of these other vasopressors are limited by their side effects. For example, dopamine isn't typically a first-line agent simply because it has the highest rate of arrhythmias. Going through these agents, the major difference between the vasopressors is their receptor profile. So as we have our alpha-1 receptors, which is responsible for vasoconstriction, and then we have our beta receptors, beta-1 for heart rate and contractility, and beta-2 for bronchodilation and vasodilation. And that's one of the reasons why norepinephrine is our first-line agent, has a little bit of both. And then as you move on, epinephrine has a little bit more beta, so a higher risk for things like tachycardia, tachyarrhythmias. Phenylephrine is interesting because it's only alpha-1, so it causes vasoconstriction without any increase in heart rate. And actually what you might be seeing is a reflective bradycardia, which is the main side effect of phenylephrine there. We have dopamine, which I already spoke about, and then vasopressin, which is an adjunct vasopressor. We never use it as monotherapy. Basically what that does is it increases vasoconstriction, also has a weak effect as an antidiuretic hormone as well. Most of these, as you see here, we have maximum doses, but there's no real maximum doses for vasopressors. This is just general guidance, so you may see doses as high as like 50, 60 mics per minute of norepinephrine. For our campus specifically, it's important to take a look at the units, specifically with titration instructions, just because certain units and providers are used to ordering in maybe nanograms per kilo per minute, but generally we've tried to standardize our mics per minute as what we're going to in our pump. Now, under normal circumstances, it's recommended to be using a central line for these patients to reduce the risk of extravasation, which is the major complication of giving it through a peripheral line. However, because of the current situation that we're in, we're recommending using the lowest concentrations as possible to use peripherally for these patients. And one thing to also note is that vasopressin should not be administered via peripheral line because we don't have an effective antidote, whereas the other ones we do have an effective antidote for. One thing we've been doing too, because as we see, we're going to be having more patients on the vents, more patients on sedation, more patients going to be requiring vasopressors, is that in an effort to conserve our resources for vasopressors, we've been recommending to our ICU leadership to start midodrine, 20 milligrams Q8 up front to reduce the amount of IV vasopressors our patients are actually going to need. So what midodrine, you can consider that to be an oral vasopressor. It only acts as an alpha-1 agonist. So something you might be seeing ordered a lot more, especially for the ICU patients. Then we have some general extravasation management that we include in this guide. Just remember that it does not apply to vasopressin extravasation. And then finally, we have the supportive care for the ICU patient. So and what we've also been seeing with more and more data coming out with COVID specifically is these patients tend to be a little more procoagulant than what we're used to seeing in our inflammatory shock patients. So making sure adequate venothromboembolism prophylaxis is on board is very crucial for these patients. So we also want to try and limit the amount of nurse and provider contact time as much as possible to preserve PPE. So what we've been recommending for patients with normal renal function is the use of Lovenox once daily. But for those that have impaired renal function, and we'll go over a few cases what that might look like, heparin 5000 Q12 instead of Q8 is also a good recommendation to make sure is on board as well. And then we have what we call stress ulcer prophylaxis. So for patients that are intubated for a prolonged period of time, who are procoagulopathic, or just don't have very good gut perfusion, have an increased tendency to have gastrointestinal bleeds. So what we ensure all of our patients have that have been intubated for a prolonged period of time is the use of PPIs or H2RAs. What we're recommending right now is the use of once daily medications, once again, to try and reduce the amount of contact time our providers have with the patients. So once daily pantoprazole, if your creatinine clearance is adequate. Esomeprazole can be given through a nasogastric tube, which is very helpful. And then we have our H2RAs, which are renally dose adjusted. So for example, if your creatinine clearance falls below 50, you'd be using famotidine 20 milligrams daily versus the twice daily. So other general management for these COVID patients. So as we kind of talked about clustering medication time. So if you notice the use of TID or BID, what this will default times to, at least for Mount Sinai Hospital, is 10 a.m., 6 p.m., or 10 a.m., 2 or 4 p.m., and 10 p.m. again for the TID dosing, to try and make the administration as easy as possible for the nurses, and will also preserve PPE. So they'll be very grateful if you can make those recommendations as you're chart reviewing and seeing orders come through. We also have been using Plaquenil upfront for a lot of our patients, which we can talk about in a completely separate setting, which is the thought is that we're trying to reduce the amount of time that the virus is active in the body and reduce shedding. So this is the typical dosing regimen that you may see. We're not recommending changing the dosing because it does default to Q12 until at least the third dose has been given so that you can cluster medications on top of that. And then general things to look out for Plaquenil are QTC prolongation, which seems to be the main limiting side effect allowing this medication to be given for these patients. And then again, evidence for this and most other COVID-specific treatments is anecdotal at best. So this will be ever evolving. Conserving our stock of IV medications by using PO, nasogastric tube, or whatever routes that we have available whenever we can is great. So in patients that are generally hemodynamically stable or who are tolerating tube feeds, we can use our enteral axis there. We've been recommending discontinuing low-value medications such as Docusate and switching to either more preferred agents or agents that can be given once daily or twice daily. Transitioning to extended release products as long as the patient is able to take it enterally. These products shouldn't be crushed, so that's another great recommendation we can make. And then monitoring renal function daily because these patients will have rapid swings, especially if they progress deeper and deeper into their ARDS and their hemodynamic shock. So for the remainder of the time before we go to the Q&A session, we did want to go over a few cases with everyone just to kind of show how we generally approach and manage these patients. So for our non-ICU patients, what you'll generally see is that they're being admitted generally for respiratory distress and hypoxia. Maybe it's because they're having difficulty breathing, they have comorbid respiratory conditions on top of that. They need a hospital bed because they need oxygen. They need to oxygenate better. So what we have to offer and what you'll most likely see in your general COVID case are things like standing albuterol and ipratropium, which are bronchodilators to help with the work of breathing. The Plaquenil, which we discussed already as a measure to reduce viral shedding. Antibiotics, so whatever your specific hospital nomogram is that you use to treat community-acquired pneumonia. Some of these patients do end up coming in with it started off as maybe viral with a few symptoms, but progressed to an actual pneumonia. So it's not uncommon to see things like ceftriaxone and azithromycin being used. What we have noticed is that a lot of these patients do have hypertension as a comorbidity. So we've been seeing a lot of antihypertensives. And then finally, because of the procoagulant nature of these patients, you'll definitely be seeing a lot of VTE prophylaxis and treatment.
And so particularly for these floor patients, this is probably where we can have the most impact with clustering medications. Often because these patients are so stable, the nurses only check on them like once or twice a shift, very minimally. Whereas in the ICU, they still have to go in and turn patients who are paralyzed so that they don't develop pressure ulcers. So clustering medications, I would say if you can only do it in half the charts that you look at, I would focus on the non-ICU patients.
Definitely, highest role, highest impact. And not all patients are going to have a lot of medications or comorbidities in general. So this is an example of a chart we went through the other day where this patient was only on Lovenox for VTE prophylaxis. However, what we're noticing too is that a lot of providers, because of how swamped they are, don't have time to put in the general information like height, weight, etc. So it's really important to make sure that we're looking at things like creatinine clearance, knowing that Lovenox is something that we renally adjust. So one thing to kind of take away from this chart right here.
Yeah. And particularly for everyone at MSH, because historically heparin was our VTE agent of choice, I think providers kind of forget and are also very busy, so they have missed a couple patients who have developed AKI and remain on Lovenox. So that's one potential way in which we can support our colleagues and really prevent harm by making sure that, the Lovenox that was ordered a couple of days ago is still appropriate for that patient and who they are now.
Absolutely. So when you're reviewing these charts, these are the general approaches we've been taking for these floor patients. So the first thing we'll look at are how well are the patient's vital signs? Are they able to oxygenate okay? Does that mean, is that the explanation for why they're on the albuterol, the ipratropium? But more importantly, things that are managing their blood pressure, making sure that these antihypertensives are appropriate and that we're not giving things like Norvasc 10 to a patient whose blood pressure is 80/40. So double check that before you see these orders going into play, because things can change very rapidly with these patients. And then going through the labs, I think the most important things, if you are constrained by time, that you should absolutely check in every patient, include a CBC to make sure that the platelets and hemoglobin are appropriate for VTE prophylaxis or treatment. And if you do see elevations in white counts, we are seeing steroid use, especially in the ICU patients, become a lot more common and frequent. But it could also be a reflection of, just how inflammatory these patients are, or maybe they do have another infection on top of it. With the Chem7, we want to make sure that you absolutely calculate creatinine clearance on all patients, and we'll talk about AKI on the next slide just to give you a little primer. But in some of these patients too that maybe have heart failure on top of having this COVID infection, or that are just generally accumulating fluid because of the disease, you might see diuretics being used a little bit more, which you might want to check things like their electrolytes, specifically sodium and potassium. And finally, reviewing the EKGs for all these patients, just so that we have a baseline, which I believe is the current protocol right now before starting Plaquenil. It might not be, but making sure that we don't see drastic raises in the QTC can lead to ventricular arrhythmias. But we want to just make sure that the risk is minimal, and that it can be compounded by other QTC prolonging medications. Some of the more common ones that we've been seeing are the use of methadone, antipsychotics, specifically first-generation ones over the second-generation ones, antiemetics, and even some antibiotics, specifically azithromycin. For those of you that want a quick refresher on what acute kidney injury is, there are quite a few definitions, but the most commonly cited ones and the most commonly ones we use are an increase of 30% of their baseline serum creatinine. So for example, if my baseline creatinine is 1 and it jumped to 1.3 in 2 days, that would be a 30% increase. Or a doubling for patients that might actually have a low serum creatinine to begin with. So for example, going from creatinine of 0.3 to 0.6, 1 to 2, etc. And finally, the most important marker of renal function that we have is actual urine output. So things like oliguria, which is defined as less than 0.5 milliliters per kilogram per hour, or maybe you see diminishing urine output, which you can check in the flow sheets if your site is using EPIC. It can be difficult to distinguish from chronic kidney disease because of coming in with an already elevated baseline creatinine. So that's why it's important to know what that patient's baseline is, or their baseline urine function is, and definitely be cautious in our more elderly and malnourished patients because they could have reduced muscle mass, which is what our actual creatinine in our serum lab that we're monitoring is coming from. So here's another example of a case that we went through. This is a 90-year-old patient who's 5'6", 67 kilos, so about a normal size, who was ordered for Lovenox 40Q24. Walking through this chart, we have our antihypertensive, we have our DVT prophylaxis with Lovenox, we have the Plaquenil that was ordered as a load and the maintenance, which are joined together, and then we have some of the patient's home medications as well. But looking at this patient's creatinine, just kind of like Sarah was saying earlier, came in with a somewhat normal, but we saw that it had increased well over 30% over the past few days and is starting to come down again. So these are the patients that we want to take extra care of to make sure that the Lovenox is appropriate, because it can accumulate and lead to an increased risk of bleeding. And now for some general tips and chart review for our ICU patients. So these are the patients that are going to be ventilated and intubated. All the general measures for the floor patients still count for these patients, with the exception that you might see different types of antibiotics based on when the pneumonia was diagnosed, whether it was hospital or ventilator acquired. the addition of stress ulcer prophylaxis, which we went over, and then some of the other things that we talked about earlier that are in the ICU handout that we sent out. So the need for vasopressors, analgesics, sedatives, paralytics, and steroids as well. So this is a chart of another patient. This was a 55-year-old male who's been admitted to our ICU. One thing we've been noticing too is that these patients are a little bit on the larger side, so don't be surprised if you do see BMIs of 30, 40, even 50 or 60. But this is someone who has his chronic medication, an antibiotic that's on board, PPI for stress ulcer prophylaxis, a heparin infusion. So this is a patient that did end up having a venous thromboembolism. Steroids, and our steroid doses are going to be ranging quite a bit, and the agents that we're using. So most commonly that we see in sepsis from the sepsis literature is 50 Q6 of hydrocortisone, but other recommendations you might start seeing too are dexamethasone 4 Q6, as well as methylprednisone 1 milligram per kilo over 24 hours that may be split into 2 separate doses. But more to come with that once we learn more from our ICU leadership here. The Plaquenil and another medication for bowel regimen. But more importantly, what to highlight here is the use of an analgesic drip that's set to a fixed rate here of the dilaudid 2 milligrams an hour, as well as Versed 4 milligrams an hour for sedation, ensuring that these patients do have a RASS score of -4, -5 before we add on the paralytic agent. Because one thing to remember is that paralytics in themselves do not offer any analgesic or sedative support. So whenever you're verifying orders for paralytics, please, please, please make sure that the patient does have a analgesic or a sedative drip on board.
Definitely the sedative has to be there.
Yes. And then this is an example of a patient I was able to make an EPIC playground. Here, when we're just going through the profile, we see that DVT prophylaxis looks okay. Maybe the patient has acute kidney injury. That's something we would be investigating. The hydrocortisone is a different dose, but it's close enough to what we've seen before, so we're okay with it. The patient does have stress ulcer prophylaxis, which is good. But the thing that would raise my alarms specifically for this patient is seeing a paralytic drip without any kind of analgesia or sedation on board.
Mute your mic.
So hopefully this was helpful for you guys. You can come back to this talk and use it as a general reference for COVID general care or an introduction to ICU pharmacy, especially as your roles are changing. And with that, Sarah and I would be happy to take any questions that.
All right, Sarah and Paul, thank you so much. This is Rick coming back on the line. So for anybody who has questions, a couple of options. One, if you're on the web, you can type in a comment and we'll try to pull it up that way. If you want to try to ask your question, feel free to use *6 to unmute if you're on the phone. If you're on the web, you should see an icon next to your name where you can unmute, but just, try not to talk on top of one another. So any questions, we would entertain those right now. Feel free to either type out a comment or we will go ahead and let you unmute your lines. I have one coming through. Question is, can we email out the handouts? Yes, absolutely, we will email out the handouts. I apologize, there was a technical snafu. The slides got out of sync a little bit with the commentary there, so we will definitely email those out. And if we get the chance, we may actually try to re-record that a little bit. So long story short, yes, slides and handouts will come out afterwards, as well as a link to where we're housing all of the ICU kinds of resources. Anyone else with questions? Again, it's *6 if you're on the phone, if you'd like to unmute, or you can click the participants box in the web and unmute your particular line if you're on the computer. Okay, I have a question here in the comments. It says, hi, do we have a policy on how much we can concentrate drips or increase in bag volume for patients requiring higher doses? I'll let Sarah and Paul speak specifically to their site. This will be a site-specific answer. So one thing I'll say is if you're at any of the other sites other than MSH, you would want to reach out to your clinical leadership there to maybe answer that question. We don't have standard concentrations at all of the sites, and we do not always have the exact same capability as far as when we want to double concentrate and or change volumes, etc. But I'll let Sarah and Paul speak to that as well. So Sarah, Paul, do you have a comment on either of that? You might have lost them. I'm not sure. Sarah and Paul might have fell off. So long story short, we don't have a standardized policy on that one, but we would encourage you to speak with your local clinical leads in ICU or your clinical leadership, critical coordinators, those sorts of folks. They can help with those kinds of questions.
Hey, Rick, I think we accidentally got muted. So for those of you who work at the Mount Sinai Hospital's campus on the Upper East Side, the document we shared shows our standard concentrations and then the max concentrations for pressors.
Thank you, Sarah. Appreciate that. I have another question. This one says, for non-COVID units, can they start paralytic agents? There's so much change, ICU may not have the space. Sarah and Paul, what's going on at your site? And then it'll be a little bit different probably for each site, but do you have an update for us on that currently?
Sure. So most crucially, no one should be started on a paralytic if they're not mechanically ventilated or there isn't a plan to mechanically ventilate the patient. Given that these patients are kind of overwhelming the system, I think many conventional ICUs and floors have kind of lost their meaning. So it's important just to assess what is the clinical scenario for that patient.
That's definitely something I would call on if I saw that order come through the queue. I'd make that a priority.
Excellent. Thanks so much, you guys. Other questions, either live via phone or any more chat messages? Another thing we will try to do, you guys, is we'll try to utilize a frequently asked question format. Sarah and Paul mentioned kind of the textbooks. Those are our textbooks that we will continue to modify and update as this COVID situation evolves. And we will make sure that those continue to be updated in the online version so that you can pull those down. Again, when we communicate out after this session, I'll make sure that all of that is communicated, how you can access those, et cetera. I do have another question. How concerned are we about the use of steroids in these patients due to, and it kind of got cut off, but maybe Paul or Sarah, can you just speak to steroid use in COVID patients real quick?
Sure. So I think this is an area of great controversy. So what we know from the SARS data about a decade ago is that the use of steroids increases the time to viral clearance, which basically means these patients have a detectable viral load for a longer period of time. It's kind of hard to tease out what that means for their clinical outcomes. But that being said, if there's an indication for steroids such as shock or ARDS or asthma or COPD exacerbation, at this point steroids should be made, the decision should be made on a case-by-case basis, but there's not enough data to say that they shouldn't be used. There is one encouraging study which was published by China. It's the Wuhan data, which looks at specifically patients with ARDS. It's hard to tease out, how severe those patients were because only one of them was on a ventilator. But what they report actually is a reduction in mortality for those patients who received methylprednisolone. So although that's not a case closed kind of article, it does indicate that maybe there is at least no harm, if potentially no benefit, but that should be made on a patient-specific level, that decision.
Okay, thank you, Sarah. A follow-up question to that, the question is, do we need to convert blood pressure medications from PO to IV, or should we just manage the blood pressure with pressors? So I'm not sure about how you want to answer that one, but that's the question on the table.
Do we need to compare them both?
So
Yeah.
I think for patients who are acutely in shock, without exception, they're probably going to require pressors for management of their hypotension. As that begins to resolve and their pressor requirements come down, there is a potential to use oral agents like midodrine that Paul mentioned. For patients who are stable and hypertensive, in most cases, it's probably reasonable to continue their enteral medications. There might be some scenarios where IV needs to be utilized, such as, you know, they're altered and unable to take PO, or they don't have enteral access, or they need to acutely gain control of some sort of hypertensive crisis.
Great feedback. Thanks to both of you on that. Any additional questions that we can answer right now? Feel free. I'm not, oh, here's one more. Do you have a table available to make it easy for us to see PO to IV on different BP meds? We
don't have a table specifically. In terms of like the antihypertensive medications, oftentimes LexiComp has recommendations on converting, for example, with like metoprolol and other agents.
Perfect. All right, I'm going to go ahead and say we're going to draw the Q&A to a close. We will be posting this session available online, and we will distribute all of the collateral that we discussed or used on the session today, as well as additional resources. And the ICU and ED practitioners are meeting regularly to update this information and make it as germane as possible. We will also be communicating with you guys additional ways and resources to better ask these types of questions and try to get feedback back to you in reasonable amounts of time. As you can likely tell, the ICU teams, the ED teams are very busy, stretched to the max, as we all are. So we're just being very diligent about how we want to roll that out. So stay tuned for information on that as well. I thank everybody for your time today, and look forward to working through any and all questions and issues that arise around taking care of these types of patients. Thanks, everybody. Have a great afternoon.
Thank you.